All right, everyone, welcome. I see we have a pretty good turnout. People are starting to pop in. So we let the participants kind of watching the numbers there enter the room. So anyway, we got a fun hour for you. And I'll just say that we're going to talk a little bit about the journey that at least my practice has been on. And Lee is really the expert on this and has helped a lot of practices transition into printing 3D provisionals. And so we want to talk about this from a couple perspectives, but I will say that it is really a doable thing for pretty much any dental practice that's scanning. Okay. And so what we want to be clear about is how we're going to do it. And we'll talk about it as what if you just got a scanner? What if you've got a scanner and a printer? What if you got a scanner and and software and a printer? And so trying to get all these pieces of technology together is sometimes challenging. But what's helped us tremendously in the process of 3D printing is definitely utilizing the laboratory to do some of the parts of this that we don't do often, which is marking margins and some of the things that are tricky. Lee, do you have any comments about this in terms of what it's kind of doing for your practice and predictability and things like that?
Yeah, no, thanks, John. So yeah, we're gonna go through some cool stuff, and the ability for the technology to bring us all closer together and work closer together is like it's never been before. So don't think this is something that's not achievable. We do it every day. And like John said, some people just have scanners and we do most of the work. John does a lot of his initial design and we touch it up and send it back. So there's a lot of ways to do this and enter it. But the main thing we want to leave you with at the end of the evening is you get a superior temporary restoration. And we all know Pankey Dawson. I mean, that's one of the key things in getting finals exactly the way they should be. So we've got some cool stuff we'll show you tonight.
The goals of this presentation, number one, is we do want you to understand the key components of digital case planning. And if you're going to do a 3D printed provisional, you do have to start with a digital design. And I get asked that a lot. Can we start with an analog wax up and do a digital design? And I suppose it's possible, but it's just the wrong way to do it. It's way too much work. So, if you're going to do a design, put the wax aside and do it digitally. We're going to recognize the critical role of the provisional restorations to optimize efficiency and the final aesthetic occlusal result. And Lee just sort of really kind of, that's the foundation of a Pankey philosophy in terms of working things out. And the one thing I'll add to it is that, unlike a provisional that we're making direct in the mouth, if we do this technique the way we're going to show you, you're really putting in a prototype. You're putting in something where we can check margins, we can check incisal edge, we can check the occlusion. And if it's dead on, they can take that same file and make it individual and send it to the mill. If you are a situation where you make little changes, you can scan that, they can overlay it, make the little changes, make it into individual teeth and send it to the mill. So it adds a tremendous amount of efficiency. And I think the ability to really be exact in going from our provisional phase, or at least our digital design phase, to the final outcome. Again, we want to discover the impact of 3D printed prototype and why this is the game changer. And then identify the necessary software and hardware, kind of look at the different ways that we can do this, and then learn this process of implementing these strategies, depending on the software that you've got. So again, as we go through this, there is going to be a prototype or a protocol that we follow, and that we're going to begin with scanning. We're going to begin with getting data, getting photographs. There's going to be a three-dimensional plan that takes place. And as Lee mentioned, I know we do a lot of this in-house, but I would say a lot of practices outsource this, and we can talk about the advantages and disadvantages of this. If you're working with a lab that's doing this for you, understand that they have all the data there. All you really need to do is send them the prep scan and they can follow a lot of the protocols that we're going to talk about to be able to send you back an STL to print. So then we're going to be printing, talk a little bit about that, talk about why this is really viewed as not just a provisional, but a prototype, which I think of as differently, and how this can then drive a really nice final restoration. So we're going to start with, of course, recognizing that to do this, you want to have very sound aesthetic, occlusal, biologic, and tooth-by-tooth structural integrity goals, and we can't do this without all of that. And so I just want to talk a little bit about the digital technology that happens to work up to the point. So you've got a little bit of an understanding of this concept of the traditional treatment goals and the contemporary tools that we have. So we're definitely going to have aesthetic goals. We're definitely going to have occlusal goals. And then as we take these concepts in our mind, we're going to have hardware and software that we're going to be utilizing. I would say probably most of the docs, the dental teams on the webinar tonight are probably at least scanning. And again, you are going to have digital data to be able to at least do a proper design. We're also going to talk about printing, and you know, for a while we were milling provisionals, and while that's maybe appropriate sometimes, I think in the world that we're talking about doing it same day, there isn't any question that 3D printing is going to be superior and faster. And as we move along, you know, this is going to be probably the only way we do it. Software, again, is critical to be able to do the design and mark the margins and create the restorations. But again, what I want you to be thinking about in your practice is who is going to own the software. We're going to assume you have the scanner, but who's going to have the design software, and who is ultimately going to have the output creation device, the printer. And it doesn't necessarily need to be the practice. So this is what I want you to think about. I see a lot of practices that have the scanner and the printer, and they are relying solely on the technician to do everything else. And in the virtual world we're in, that is not difficult to do with TeamViewer. And you might want to comment on that, Lee.
Yeah, I mean, the technology has brought us closer together than we ever have. So there's really no walls between who does what anymore. There's just so many ways that we can work together digitally and pass the data around. So we can make things, you can make things, you can design things, we can finish things. I mean, anything that you can basically conceive as a workflow digitally works, and they all work very well.
And I see that a lot of the practices that like doing their own wax ups, their own mountings, they tend to be the practices that also like to own the software because they're used to doing it themselves. The practices that are outsourcing the analog wax ups and the mountings, they're probably going to continue to do it. So, you know, in my practice, I was a traditional guy, did my own mountings, did my own trial calibrations, did a lot of my own wax ups, sometimes got help from the technician, but that's why it's well for me. So scanning is going to be key. And again, depending on the scanner that you're using, we've got experience with CareStream and Itero, and now we've just gotten into the Trios. They all work, all right? They all will get the data that you need to do this. But the main thing that I would just say is we are now kind of getting calibrated once a year. We've got a growing team, and it's just really easy for the people that are doing the scanning to get out of practice on the geometric pattern they should be following depending on the scanner that you're using. So crap in, crap out. The earlier you make the mistake in this process by getting bad data, the further you're going to be off in the end. So pay attention to that. And if you're not the one scanning, at least take the responsibility of keeping your team calibrated and look at the scans. In terms of planning, there's going to be a time where you're going to be mounting the models. And again, in our office, my son helps us with that, as does Charity, who's one of our assistants. And once the case is mounted, which is about an 8-minute process, then the scan or then the planning can happen. So again, if you don't own the software, laboratories would be able to do this. All you really need to do is give them a scan in whatever treatment position you want to work in. That centric relation, use a leaf gauge, scan in CR, and you'll be good to go. And then a lot of the things like the full face photograph can be laid on top of the articulator, and we can start really, especially when an aesthetic case, make sure that however that scan is hanging on the instrument, it's going to be in the same place that the maxilla is hanging in the patient's head. And so from that standpoint, two-dimensional planning can happen. You can figure out specifically where you're going on an aesthetic type case. And again, anything that you want to do or that you could do on stone, we can certainly do in the virtual world. Trial equilibrations can be done, which is kind of slick. Today, if you want to be bring this into like the AD2 models and you want to do the equilibration analog, you can do that without actually using stone. That maybe is a topic for another discussion, but we can do all of the plan. And then of course, if you want to visualize some crown lengthening, we can do that as well. And then we can go ahead and do the facial contour. So point being that if we were going to turn this into some sort of printed provisional restoration, one of the things that we're going to show you is when you do a diagnostic design, the geo-reference points of your diagnostic design or your wax up there can be saved as a custom tooth library that can be used later. So just kind of keep that in your brain, because that is how we save so much time. Once this wax up is done or this design is done, we can use these files to just basically lay right over our prep. So we can look at the aesthetic design, we can look at occlusal design, and if you wanted to just take the design and print a model and do a traditional, provisional with a silicone index, we can print. And I say right now, probably Sprint Ray and Asiga are probably the two hottest printers out there. We have the Asiga, but lots of clients of ours are using the Sprint Ray. But anyway, in terms of printing, if you're thinking about it in your practice, I think those are two good ones to think about, because the most important thing to me about printing is you do want it to be fast, but maybe the most important is you want it broad spectrum. You want to be able to print multiple materials. So for us in our practice, wax ups, surgical guides, orthotics, and now provisionals are kind of what we're printing all the time. Lee, do you have any comment on that in terms of any other printers that you think are hot right now?
Yeah, I think we've got so many good printers now, but it's important not just for the printer. So we're looking at some new systems just because of FDA regulations and some of the things we're getting into. But in the beginning, printers, I remember a printer that the curing instructions said, take it outside and put it on a wall in sunlight. So we have come so far. So looking at a system that actually incorporates in the software the wash and the cure, and everything is talking to each other. So actually the three pieces know what just has been printed, knows how long to wash it, knows how long to cure it. But things have gotten so advanced with the printers today, not like they were when we started 18 years ago in printing. But there's a lot of good printers out there, and more coming out every day.
So Tatiana, you've asked a couple of good questions. I'm going to get to all of that, so just hold tight. And in terms of Maria, when I talk about calibrating the scanner, I'm not talking about the physical scanner. I'm talking about the person who's scanning. So you want to make sure that the people that are scanning it are following the geometric pattern that is designed, because that's what's weird. If you have a couple different scanners in your practice, we actually scan different on the Trios than we do on the Itero. And it's just the way that the software with the scanner sews data points together. Okay. So again, the key point, this is just a a shrink wrap technique, veneer case, a very, very minimal prep case. But, you know, the point here is that when you're doing any kind of restorative dentistry that involves aesthetics, that involves occlusion, the prototype, those provisionals drive the restorative process. And I threw this case in here. It's actually my daughter's case that we're just in the process. We just finished it up. And it's done by Matt Roberts' lab, the finals. And I just want to put it in there because I do most of my work with Lee, but I want you to see that it's not just Lee and I that think this way. I mean, most good labs want to have really good provisional restorations to look at, to overlay. And so we can take the scan of our provisional, and if we give that data to the lab, a good lab is going to analyze the photographs. They're going to analyze the provisionals and start seeing if the design could be a little bit better. We can jump on a team viewer meeting and make those little subtle changes. If you're looking at this top picture, this is the basically the no prep, the very minimal prep of the teeth, and my provisional overlaid on top of it. And what we noticed in the photographs was the left side of her was a little bit short. So you can see these are just a smidge longer. How in the world would a lab know to do that if they didn't have some sort of provisional overlaid on the preps? And so those thoughts that can then design, that can then start to drive some nice milled restorations that can then start being thinned out, that can start to be micro layered, and we can start having really, beautiful results. And this is just a minimal prep type case, but good aesthetic results and good occlusal results require us to start having a design that goes in the mouth that we can then test drive appropriately. Okay, so this has been around a long time. I would say my 32 years of this, it's just been the last couple of years that I'm going away from provisionals that I made directly in the mouth from a wax up or a digital design. And while this works, keep in mind that a provisional made directly in the mouth, there is no way that it's going to fit nearly as good as one that we can 3D print from a scan of retracted tissue. It's going to be inferior, right? And so not saying that this process doesn't work, because it does, but I think we can go another level. So let's talk about this, how we went through this in search of the exquisite provisional restoration. And one of the things that I was going to put in here is the concept of shell temps. And shell temps was a cool thing, and Lee has helped tons of doctors to do that. And it's certainly an option for you. And in the concept of a shell temp, we still do a diagnostic design, but we can instruct the computer to lightly prep the teeth, and Lee can fabricate or print a shell that can come back to us that can reline. So Lee, talk a little bit about that, because I want them to at least know that exists, but maybe then talk a little bit about sometimes where it fell a little short.
Sure. So with the software, we can program, once we get the diagnostic design done and we look at the natural teeth, we look at where we want the teeth to be, we can actually program the computer to prep exactly what we want anatomically over the tooth. So normally we're doing a 0.5 millimeter of preparation, and the computer just does it for us. It just takes everything and takes it down 0.5 millimeter and then reduces undercut, so we truly get a shell temporary. Now in the past, this is not something new, just another way to do it. We've been making shell temporaries for 20 and 30 years, but we really didn't have a way to relate them in the mouth. So one of the problems with shell temps is when you go put them in the mouth, you don't really know where they go because they're kind of floating around. So one of the things we developed in the software is a way to make a framework that actually on the upper goes on the palate. And the uppers are a whole lot easier because we've got a lot of hard tissue up there that we can register back to, but we'll make a frame that goes on the palate that hooks to the temps and actually puts it in the right position very, very easily. We can do the same thing on the lower. We just have to go to the lingual and some of the bony areas in the posterior to be able to get that perfectly lined up. And then it's just making sure you prep enough off. But the software, like I said, we use 0.5 millimeter. So we've got a lot of room for preparations to go up inside. Once that's done, you're going to reline them with a variety of materials. You can use acrylic, you can use a BIS GMA, and John will talk about what he does to make sure everything bonds together. But then you remove them out of the mouth, take away the framework that holds it into place while it's curing, and then polish up those little areas. But we just did a full upper and lower case today. And the doctor, I said, well, this was his first shell temp case. I said, how'd it go? He goes, it was perfect. Everything went in. We, did everything you said. The occlusion was perfect. We took off the framework and everything was wonderful. So it's another option in our armamentarium.
Yeah, and what I would say from my perspective, and I loved it when we went to that area, but here again, occasionally when we do it, if it doesn't seat, it's binding somewhere, that can take a little bit of time.
Yep.
And then you still have, when you're pulling it out, you still now have to trim all the margins. So if it's an upper and lower case and you're trimming 28 margins, that's still a lot of work. And the one thing about what we're going to show you next is that all goes away and you end up with these perfect margins with good embrasures that are going to give you superior tissues. So let's talk about, just aware that the shell temp is an option for you, but let's talk about what we're here to talk about tonight, which is we're calling this lab assisted same day printed provisional. And here again, if you have the software and you have a printer, you can do all of this in house. Yep. I just love using the lab assisted because marking margins in the heat of a prep, and there's just things going on that where the software is glitchy and you don't do it all the time, it can be frustrating. So we've just found this to be really, really good. So the first thing is just from a required data, remember that what is going to need to be, what the lab is going to need is they're going to need a diagnostic wax up scan. And what we sort of mean by that is we're going to need an STL of the wax up. So once a wax up is done, you need that file, that digital file. You're going to need a prep scan. And again, there's arguments about, do you do it before you retract or after you retract? And I've gone both ways. But since now we're looking at this as a prototype, I always send the scan as if it's the master model. Because if I send Lee the master model, then, to make the provisional, then what I'm getting back is really allowing me to really make sure my margins are perfect and all that stuff. I'll know that right then. Obviously a bite scan, the antagonistic scan. So you're going to be giving the lab some data. There's a few more things that we'll talk about in a second. So again, take your time, get a good retracted scan, make sure you can see the margins. And again, in terms of that diagnostic wax up, it's going to be done digitally. If you're working with the laboratory, get on a team viewer with the lab, go through it with them, make sure that you're happy with the incisal edge, you're happy with the anterior guidance, like everything. And that's the beauty of digital, is that you don't have to wait for them to send you something. You can jump on and check it before you do anything. And once that's there, that's going to be really important. We got to have good preps, got to have good reduction. Want to be thinking about workspace efficiency, which we'll be talking about, but good clean margins is going to be a key to this, because if you give a scan like that and it's easy for them to mark the margins, they're going to be able to give us back a STL that looks like that. And all the interproximal embrasures that you're seeing there, you're not going to have to create any of that. Okay. So again, imagine what's going to happen here. So if the lab has the design in advance of your wax up, once you prep the case, you pack the tissue, you send that to the lab. They're basically going to take the wax up and attach it to your prep scan. They'll mark the margins and there's no design here. They're just going to basically merge the data. That file will get sent back to the lab or back to the office. And then what we will do is put the little supports on it, send it to the printer, and it's basically going to print. There's the little supports. We'll take the supports off of it. That's essentially what it's looking like before we've done kind of any of the cleanup. Just get all the supports off of it. Then we're going to use a 99% isopropyl alcohol. We recommend you don't put it in the same wash station that you put your models in. Just use a little spray bottle, mask, gloves, use compressed air, toothbrush, just clean that all up. I don't have a lot of time tonight, but I spent an afternoon watching, having Lee teach me how to stain and glaze. You can make these things look as fancy as you want, and then we're going to cure it. So this process, and we asked about time, it seems like there's a lot going on here, but generally, if we are scanning and we send the scan to Lee, we usually can have the file back in about 20 minutes, and then we'll send it through the ASIGA, print probably in 30 minutes-ish, and then we'll do these things. So usually it's an hour to an hour and 10 minutes. We have a perfectly fitting provisional in the patient's mouth. And we just got the new trays from, I forget what they're called, the lift trays, I think they're called, from ASIGA, that's supposed to increase the time by, decrease the time by 40%. That's one thing. Sprint Ray has some options that's a little faster, but about an hour to hour and 15 minutes should be the goal here. And, they say, well, what do you do at that time? Well, if you think about it, if you, like with Marvin today on that 28 unit case, trust me, he spent more than an hour adjusting 28 margins. I mean, there's way more time involved in that. So this is the first case we did, and I want to give my daughter credit because it was actually a full case she's working on, and we thought it was a good one to try with Lee. I was actually flying to Japan. This was May 16th, a year ago. So I've been doing this a little over a year now. And she wanted to start this case. She was going to get back to the periodontist, but had to have some teeth removed. And she wanted to prep a few teeth and basically get a provisional in the lower to basically to get the plane straight, and then to start the process of getting the mouth biologically healthy, and then move to kind of doing the full case. So this was her design that she did, kind of visualizing a little ostectomy on the bottom and just leveling that plane. So again, the step one in this case is going to be doing a diagnostic design that visualizes the optimal aesthetic and functional outcome you're looking for. And so, to be clear, we do this part in our office, but we are a little unusual. I mean, I would say if Lee would be honest, he'd probably say probably 90% of the docs that he's working with that does this, you're doing the design. Is that right, Lee? Would you say that's about right?
Yeah, let's go up to 99.
Okay, all right. And we've got, in our group, we do have more and more people that are utilizing software. So I see a little bit more of that, but they all don't, of course, work with Lee. But again, just want to be clear that lots of options here. And we're showing 3Shape here. You can do this absolutely the same way with Exocad. So both of the softwares will allow you to do this. Okay, so we start with a design. And then the second thing that we have to understand is, if the lab is going to help you, and again, this is where if they do the design, they already have this, they're going to make a file or an STL of the wax up. So this blue model down here is just is basically a model. If you were to print it, it would be a model of your diagnostic wax up. And then the individual teeth that we've waxed are called elements. And so the lab is going to need the STL of the wax up, and they're going to need these individual elements in advance. Okay, so, and the third thing that they're going to need is to know when you're doing the case. So pre-schedule it with the lab. They don't want to be called in the middle of a busy day. So we always call them in advance, say, hey, expect the prep scan around 9:30 or something like that. And that way they can put it in their schedule as well. Anything else, Lee, or is that?
No, and I just wanted to point out and make clear to everybody. So the only scan you're really doing on preparation day is the preparation scan.
Yeah.
We've already got everything else and we've already designed or you've designed. So the file is sitting there. So it's not like you've got to go do a lot of work other than prep and scan the prep scan and send it to the laboratory.
Yep. And that's the key. If you are doing some designing yourself, though, just make sure that's a great thing to give them a couple days in advance
Yes.
when you're pre-scheduling, because you don't want to be scrambling looking for all that stuff while you're prepping. Ask me how I know. All right. So now the next thing is the day of the prep. And so what we did, or what she did in this case, and we do it a little bit different now, but we were still thinking about trying to save time. So what she did was she went ahead and prepped the 3 teeth that were going to be the preps prior to the extraction. So she prepped 3 teeth, didn't take the teeth out yet, sent the scan to Lee. And then what Lee was going to do is virtually extract the teeth and make the bridge, which was fine, except now he's really guessing where the gum tissues are going to be. And again, it probably did save a little bit of time, but in this case, she ended up with, he guessed a little bit wrong, and now there was a lot of grinding. And if I'm not mistaken, she even told you that she had to grind she gained respect with you that one day because she talked like a dentist.
Yeah, use a lot of curse words.
So anyway, probably the best way to do it: prep the teeth, take the teeth out, sew it up, get a good scan, and now you can make a provisional that fits perfect. Put a little pressure. So we're thinking less about. It's not a big deal for us to wait a little bit for a provisional now, but this is how she did it. So she prepped, she scanned, and then basically emailed that to the lab, and she started taking teeth out. So let's show you what happens at the lab. So you want to talk about this, Lee? So basically, you get your master model.
Yeah, so once she sends those preps down, she's prepped the teeth, but the teeth are still there. So in the software, I can extract the teeth and model the tissue the way in a guesstimate of the way I think it's going to be based on based on anatomy and based on extraction, past extractions. So we just tell the software, extract these 4 teeth, it does it. I'll sculpt the tissue, and then we're ready to take that design and bring it into the software and place it on the preps.
Yeah. And again, marking the margins at this point as well, correct? Yeah.
Yes.
So one of the things that is important that you can see is now that we have the wax up, if you will, or the diagnostic design, the STL of the diagnostic design, this is where data stacking is so powerful, because you can take the STL of the diagnostic wax up and lay it right over the preps. And so this is incredibly important, because now we know exactly where our design was in relationship to the preps, and then the individual elements of the actual wax up will kind of snap into place, and now your wax up is right over the preparations. And so this is how we say, or the lab saves so much time, because they're not doing a wax up that day. That's already been done. Any other comments there, Lee? Or is
No, so once we get that design, we can save the diagnostic design to be used later, and we just position it correctly over the preps and then attach it to the margins we've marked.
Mm-hmm. And so at this point, when you lay that in, the software will line everything up to where you've marked the margins. There might be a little bit of cleanup, but at this point, the STL can be sent back to the office. So obviously, the more preps there more be a little bit of time. But if they get right on it, I mean, this is not a time-consuming thing at all for them to be able to get that and get back to us.
Yep.
Now, we went through the process, or she went through the process. What was so cool about this for me was I was flying to Japan, and this is the world we live in right now, but I'm up at like 36,000 feet, and I'm getting texts from both Leah and Caitlin as this is happening. So I'm getting the play-by-play as this is going on. So we printed this, and Lee took one look at this and wasn't impressed. because you can see the little striations. And again, at this time, we were thinking about speed. So we were printing at about 100 microns. And so, printing at 70 or 50 is probably a little bit crazy, but 70, you won't see any of those striations. And again, printing at 100 probably saved us 5 or 6 minutes, but now we have a way more finishing to do. Yep. So it's just better to just let the printer print in a way that you have a whole lot less finishing. Comments?
Well, the one thing about when you talked about milling versus printing, so the reason we like printing so much is you will get exactly what you design. With milling, the milling burrs really can't get deep into those interproximal crevices to give you that perfect contour. So when you mill things, because people go, well, why do you print it instead of mill it? The printing materials are up to the strength, if not beyond, of some of the milling materials now in PMMAs and some other things we've got to mill, but you just don't get the detail that we do in printing. When something comes out of the printer, once we clean it up, it's literally ready to glaze and put in the mouth.
Yeah. And I've seen you'll sometimes accentuate things and paracamata, and you do that lab stuff that that makes it look really extra nice. But honestly, I'll show you one here in a minute that we didn't do any of that, and it still looks very, very good. So this was where she started. This was the design. This is the provisional that dropped in the mouth. And this was before we were getting fancy with any kind of staining and glazing. But still, there was a lot of high-fiving going on because it just fits so nicely, and we realized that we were onto something. So since that process has happened, we've done a bunch of cases with this. And so I want to show you Christopher's case. And this is a special one for me because this is one of the patients that I'm utilizing for my Pankey Scholar for my Part B, which is coming up. So let's just kind of look at it from that standpoint because we want to test it from a lot of different perspectives through the Pankey lens. So pretty healthy guy, 54 years old, has some gingivitis. We did find in his exam, not going to get into it, that had a sleep study, and he did have some sleep apnea that we ended up getting him taken care of with our local guy with a CPAP, but pretty much just wants a new smile and has that pretty typical concave lower incisal plane. Has got one PFM on a central, so you can kind of probably see where the incisal edges once were, but just has that, just look of what we see with a lot of baby boomers. He's unhappy with his smile, but it's being driven from underlying functional problems. So we're going to go through our process of taking our pictures, looking at our E and our rest and our profile and our tip down smile. And for brevity, not go through all of that, but essentially coming up with a plan of where we want these teeth to go incisally. And so from incisal edge up, we want to plan that first kind of aesthetically. Lower incisal plane will also be kind of thinking about where we want that to go. I am going to be doing porcelain up top and doing some kind of bonding and reshaping on the lower for the short term until he can come back next year and do porcelain down there. But basically going to try to get his occlusion and his upper aesthetics looking as good as we can in this first phase. So lots of pictures, scans, and when I saw his wear and tear, I wasn't 100% sure whether I was going to be able to restore him at his vertical or if I was going to need to open him a little bit. So I actually took a CR scan with a leaf gauge at a slightly open vertical. The left scan is his MI. We took our films, took a CBCT on him as well as an FMX. And one of the things that we like to do is look closely at the joints. And there's the scan, looking at it both in MI and as well as popping it back in centric relation. So one of the things that was interesting is we had him in a deprogrammer for about 5 months before he worked, and before we did the work on him, and also with the CPAP. And his jaw actually came forward a little bit. So you can see he's heavy in the premolar areas as well as in the front. So once we were ready, we went ahead and got him mounted up on the articulator in centric relation. Again, one of the things I want you to see is we can open and close in centric relation. You know, we can close them down and look where the interferences are. But what I'm going to do is take that digital plan of where I want the upper teeth to be. You can see on the lower, I'm actually going to shorten the canines a little bit while I'm raising the lower incisors and try to get a flat plane of occlusion, lessen the overbite on the canine so I can shallow things a little bit. Kind of visualize where I'm going to go. And then we're going to make sure that our mounting is accurate. And again, what I want you to see is when we overlay that, we just want to make sure that that scan is attached to his maxilla in the photograph, and then everything's lined up with his eyes. We then can go ahead and start doing our design of where the lower teeth are going to be. And you can kind of see how I'm shortening the canines while I'm bringing up the lower incisors. And I'm going to be kind of doing some reshaping and bonding there. And then I'll do the upper incisors as well, showing you a little bit of the plane change we're going to do. So we're going to do those facial contours first, making things a little bit more concave. And we can even do a two-dimensional design in 3 shapes as well to just visualize where this will all look in his face. So that's kind of fun as well. Okay, so that's kind of what we're thinking. Occlusally, here again, we're getting our centric stops. You can see how the canines are in class 1. We're able to do a little equilibration. We got nice centric stops on the cingulum area. And then we can also see our guidance. Let's see here. Yeah. We can look at crossover. Again, I like to bring it a little bit forward, and then we can go over the canine onto the central. And again, whether you're doing this or you want the lab to check that out for you, we can do all the things that we did in the analog world in the digital world. Okay. So now what I want you to think about is all this data. Think about Caitlin's case. I'm now going to give Lee the STL of the wax up, and I'm going to give him the individual elements of those teeth. And we're going to schedule a time where he knows I'm prepping. And then I'm going to prep the case. And so once I prep the case, I'll prep the case, pack the tissue. And if you notice, I haven't done the lower yet. And this is a way that's a time saver, because if Lee's going to take the upper scan, he doesn't need the lower doesn't mean anything to him really on this at this point, because what he's going to be doing is just basically overlaying it on top of the design they already have. So I'm going to go ahead and pack my tissue, pull the cord, make sure I can circumferentially see everything, and I'm going to get a really good clean scan. All right. And if I'm happy with my good clean scan and I look at this as my master scan and I've got plenty of ruminol, then I can go ahead and send this on to Lee. So Lee's going to get it. And why don't you talk through this, Lee, because now you're taking this into the software.
So the file's been sent to us, and all we're doing is adding. We're not creating a new file because we've already built the file. So all I need to do is mark the margins. And you can see on John's scan, the margins and where they go are very apparent. So on the cuspid, I'm actually going to mark it. So with your mouse, you're just going to be clicking along the margin and marking it just like you would with a pencil.
All right. And so would you say with 8 teeth, because the software a lot of times will give you pretty good, now it's sort of AI does a lot of this, correct?
Yeah.
And
so
then
exactly.
And so now you're really just looking at it. So that's a lot faster process than it used to be.
No, a whole lot faster process. but we're just going to mark the margin. And I did that one manually. Like John said, a lot of it, the computer will AI guess at it, and you've just got to adjust it a little bit. But here's where it gets fun. So with the coordinates done correctly, we've saved the diagnostic wax up, and it's in a library over on the side. And we've designed it to be reuse the library. So I'm going to go to my libraries and just pick the diagnostic that we've already done. And it literally, if we've done everything correct and kept the coordinates correct, the diagnostic kind of goes and jumps into where it's supposed to be. And
And
then,
what you're looking at here is the overlay of the STL of the wax up. So for
yes,
some reason it doesn't, you can actually manually move it right on top of this, right?
correct.
But this is what I think you're talking about here is now the wax up kind of just bops into place like that.
Right.
And it should be in the same position that we did the design.
And you can see the teeth are just a shell when we take the model off. So everything's lined up real, but when we go under it, see, it's just a shell. It's not attached to a prep. It's not attached to anything. So over on the left bottom is a button that says attach to margin. And all I'm going to do is push that button.
And now when you look at it, it basically takes the design and you'll see it when it flips up here that we have a gorgeous contour that's following those margins. And again, what Lee was saying, all those embrasures, like when you see that interproximal contour with a print, that's going to be just like that. With a mill, it's not going to be as clean.
Right. It's going to be filled in.
All right. So Lee gets to this point and sends the STL file to us, and then we're going to go through. Charity will do the little supports, and she'll print it and she'll wash it, and then she gives it to me, and I tend to spend a little time doing some of the coloring stuff. And then this was basically what the provisional looked like that we were going to get ready to put in the mouth. And so this took about an hour and 10 minutes to get to this point. But again, you saw what it looked like inside. I haven't touched any of these interproximal areas. And so this is to me the game changer, because now when we cement this thing, we give him like a little water pick or something, and he get all that cement out of there. We should expect to have really beautiful interproximal tissues. Those interdental coals should be really, really healthy.
Right.
So again, just kind of looking at where we were and then overlaying where we ended up, pretty darn good. And I should mention that the other thing I did on this case was I did closed flap laser surgery on 7 and 10. Took a little bone away, so that's why that's looking a little irritated. And so now he's just going to heal. And so here again with Lee, what we did in this case, since we had the master model, I wasn't 100% sure how 7 and 10 was going to heal. So I just sent him back to the Outer Banks where he lived. And I just said, don't make the crowns yet, because if the tissues don't heal well, I can always take it off and do another impression. But he came back in about 7 weeks and everything looked pristine. So I said, make the crowns. No reason to take things off and take another impression.
Nope.
And this was our prototype. So still going to check the occlusion, still going to check phonetics, still going to do all those things. And I think we changed things a little teeny tiny bit. And then all we're going to do is scan the changes. And then again, Lee will take that scan and overlay it on the design, and anything sticking through, it's easy to see and adjust.
Yep.
So here he is kind of at that visit when we first are doing it. Working on the occlusion, so getting the stops all dialed in, getting my guidance sorted out, making sure everything's nice and smooth, that we've got good smooth crossover. Looking pretty good. We'll do our shades when it's time. Lab script. And then once it's time to come back, some really nice model work. Talk a little bit about your model work, Lee, because I do see a lot of digital stuff where dyes don't come out, but you guys kind of go another level with this.
Yeah, well, I mean, one of the nice things is I work with a team of brilliant people. So we don't use standard model settings. You know, we've developed our own to do everything from getting each individual die geometry with its own fitting parameters to actually showing the computer how to remove the tissue right around the margins. So we've got a little emergence profile that we can build in there. But I have some of the smartest people on the planet working with me, and I just come up with ideas and tell them to go do it.
Cool.
But the
So,
one thing,
oh, go
because I
ahead.
was just talking to a dentist today, and since we're talking models, John, because that's again, that's the basis of everything working, is a lot of laboratories don't trust the models, so they'll do solid models. And we did that at the beginning too. So everybody goes, well, they're not going to be accurate, so you've got to put on a solid model, which kind of came from the analog world, and we did it until we didn't do it, and nobody complained about contacts. So we find our model work to be extremely accurate, both in occlusion and in contacts.
Yeah, I can tell you that for sure. And I really appreciate the individual die because I like to check each crown. It just makes me feel good. But anyway, so again, this is just a monolithic Emax. I'm sorry, monolithic zirconia restoration. And talk a little bit. This isn't glazed, you're hand polishing, but you are layering. What are you layering on here?
So really, so the zirconia is already layered. So we will go back to hand layering if the other teeth have a lot of characterization or a lot of translucency or a lot of transparency, then we will go back and layer. On larger cases like this, the zirconia is already layered. So in the disc, it's layered. When we center it, it comes out beautifully done. We can add internal effects, but what you're seeing here is technicians that I've trained to simulate internal effects and translucency with external stains.
Which are beautiful. Yeah. And again, what I appreciated and I've done a zillion Emacs and I loved Emacs, but the weak link on an Emacs was always the part that was layered. And what you have with a monolithic zirconia is just something that's going to be supremely strong long term. So here are the final restorations. They're going to go in the mouth. He wanted a little bit of extra characterization. I think his word was he was from the Outer Banks and didn't want to look like he had a picket fence in his mouth. So, but this is what the tissue is looking like when the temporaries come off. And there's the pre-op. This is what he's looking like at the delivery. And that is really beautiful, healthy stippled tissue that we see over and over again. So final restorations will go in place. Contours really should be pretty much duplicates of what we've worked out. And again, what I'm loving about this is just we've had a prototype in his mouth that has proven that it's going to work for him. And again, notice where we did that crown lengthening and how well that's healed. And then the process before day of the surgery, as well as prep and the prototype, and then the healing. Still going to work out our occlusion. Still want to see nice smooth movements. It should very much mirror. He's still a little bit numb here from the day we delivered. X-rays before and after, and then just kind of the transformation. So what I want you to see here is that, a lot of the philosophy and a lot of the concepts of occlusion, none of that's changed, but I do think this is a very elegant way for us to speed the process up. And again, from a technician standpoint, if we've now had a prototype the day of the prep that's gone in his mouth, and we know the margins are good and we are 95% there with contours, we're way down the road because we're not starting the case all over again. when you get the impression in there. And you can maybe as it's a cut and paste thing from here on forward. I mean, that's what's so cool about it.
Yep. Where in the past, in the analog world, we literally at every stage had to start over again. Here, we just keep moving the file ahead for different outcomes.
So in implementation, I want to talk to you just a few things just to give you a suggestion, and just remember what we said, that there are kind of a few process here is where we're going to scan, we're going to plan, we're going to print the provisional, we're going to have a prototype that goes in the patient's mouth, we'll be adjusting and dialing that in, and then that's going to drive the delivery. And so as you think about your own practice, if you are a practice that primarily just has a scanner, you still have to get that additional data way before the prep, the scan of the pre-op situation, the scan of what condylar position you're going to restore in, the photographs, and what you're going to do is send that data to the lab and work with the lab on the design. And so that's really, you think about it, all the design work of the provisional is the same thing that's the wax up. It's one and the same. So TeamViewer, Zoom, whatever you're going to do, communicate with the lab. Then what's going to happen is once that is all set and you're ready to go and the lab has everything that is all for the provisional, then basically what's going to happen is that you're going to prep the case. And once you prep the case and it goes to the lab could do everything we've just talked about and print the prototype and send it to the dentist. That's just a little bit difficult if the lab isn't close by. Like Lee and I couldn't do that because we're hundreds of miles apart. Now, I will say this, Lee or Kim Daxon,
Yes.
who's a friend of ours, what she does in this scenario is she gets a model of the diagnostic wax up and just makes a suck down. And she uses a denture, I think it's Co-Soft, it's white, and she preps the case, sends it to Lee, and fills that little suck down with Co-Comfort, and it goes over the teeth, and the patient wears it overnight. And they put the temporaries in the next day. It's genius. In fact, we kind of borrow that from her because when the patient is sitting there waiting for the provisional, we actually do that because if the patient starts to get sensitive, they get a little freaked out. But with that over their teeth, it doesn't bother them at all. And so often I can pull that off the teeth. It seems to kind of calm the teeth down. I get the temporaries in without having to numb them. So it's a great little trick, whether you're doing it the day of or the next day. But just keep in mind, that is a way to do it.
Yeah.
And again, from there, you're going to still put the temporaries in, and that's going to be the way to communicate to the lab to get the final restorations. I think a really easy thing to think about, though, if you've got a scanner and you're kind of wondering what to do and you like this idea, I do think getting a printer second isn't a horrible idea, because we can really talk about this protocol where basically the dentist gets the scans and all the additional data, sends that to the lab. The lab goes ahead and does the design for you. And then pretty much we can just do exactly what we just showed you. Prep the case, send it to the lab connects the margins, sends it back to you. And now you're printing it and you're placing it. And that's basically going to allow you to go ahead and deliver it and allow that to drive the final restoration. So I think there's a lot of room for dentists having the scanner and dentists having the printer, and the lab does the design. Whether it's a wax up that you're going to print, whether it's a provisional that you're going to prevent, whether you're orthotics, surgical guides, any of those things. And I know you have a lot of labs that you do that with, Lee. I mean, you do that with us a fair amount on different things.
Yep.
Next option is, what if you decide to have software second? And this is honestly what I did. I initially got my scanner. Next thing I did was got software. And the one thing I did have was Bayview close by. So Bayview was doing a lot of the printing of things for us, which allowed us to do some of this. I wasn't printing provisionals then, but they would print orthotics and surgical guides and things like this. I think if you're going to do this process, unless you do the Kim Daxon technique, I think it's nice to have a printer in-house. And then if you completely lose your mind, you could have the scanner, the software, the printer, and a mill, and you can do all these things. So there's lots of ways to do this. We just want you to understand that somebody's got to scan, somebody's got to design, somebody's going to prep and attach the margins, somebody's going to print, somebody's going to put the prototype in, somebody's going to deliver. And where it gets a little iffy today is it's getting a little blurred on who's doing the planning, because more and more that's happening in dental practices. And same thing with printing, more and more that's happening in dental practices, but you can choose which way you do it, how much you're going to lean on the lab. Got a few questions I just want to look at real quick before we go on to this next little section. Basically, one question, Lee, was I'm just starting to scan, and when the crowns come back, I'm getting a lot of having to adjust contacts a lot. What am I doing wrong? That's usually a setting in the software from the lab, isn't it? Wouldn't you say?
Well, I mean, we still go back and adjust and check contacts on the model. So if the lab has very accurate calibrated models, then we're still going to put it back on the model and check them and rubber wheel them or add a little bit of glaze or whatever to get them perfect. But it could be scanning, it could be the model printer. So it could be one of two things. But if it's printing the model,
I see them. Yeah, because he's talking about final restorations. You're talking about the model. Yeah, I got it.
yeah. Well, I mean, if the model calibration's off and you're printing a bad model, then you're going to get a bad contact.
Okay. But I think the main thing is if you're working with a lab that's fairly new, that's just feedback, right? I mean, tell them that. Tell them that that's
always.
Yeah, call them always, and they'll start dialing that in.
Yeah, they may not know.
Lee, do you prefer the clinician to mark the margins or for you to mark the margins?
Me.
Okay.
If I can't see it, I shouldn't have to send it to you to mark a margin because I can't see it. I should just be able to see it. But it's a production issue too. We've got a workflow that if we've got to stop and wait for a dentist to get online and go mark a margin and do all this stuff, it's a production workflow issue too.
So Maria was saying, so milling in office is not recommended due to not being detailed. We're not really saying that because you can do single units and all that. But what we're talking about is in multi-unit situations, getting up into the embrasures may be a little bit more difficult, but single tooth milling with the CEREC is a fantastic work.
Sure, absolutely.
Can you comment on the strength of the provisional versus a provisional you make in the office with a matrix? It's not even close. It's not even, you're going to be so much more superior with these new resin ceramics. How are you communicating with Lee during this? Primary way is, we do write a lab script and all that, but honestly, it's a properly contoured provisional. If I give him a properly contoured provisional and we write a little note, we should be able to take it home. And then anything that he's not clear about, we're constantly, hey man, what does this mean? We're always, chatting back and forth.
But the nice thing, I mean, a good provisional, but it takes 5 minutes for John to jump on a TeamViewer Zoom meeting and go, move it out, move it back. I didn't want it this way. Fill this out a little bit. Can you make that bicuspid a little longer? Where in the past, we would have been doing this all in wax. I can totally change a case with John while he's sitting there within 5 minutes.
Yeah. And again, most of the time we're seeing, most time we talk for about 30 seconds and Lee says, okay, we're seeing the same thing, and that's all we want to make sure is we're seeing the same thing. But we've worked a lot with each other. So the more you do this with a person, the more you start to know what each other wants. Talk a little, do you think 5Y versus 4Y? I mean, I like the pucks that kind of 3Y, 4Y, 5Y, but I mean, certainly you like the more translucent zirconia out on the edge, correct?
So we use a 4Y, 5Y. I've never really liked the aesthetics of 3Y, 5Y. I've been using 4 and 5 for over 13 years and have done thousands, literally thousands of full arch implant cases. We just did a retroactive study with a doctor I work with for the last 14 years and just trying to find patients and look at breakage, and we just don't see it. We're just not seeing breakage if things are designed. But the 5Y, 3Y, it's just a big difference between the opacity and the translucency. Everything that I send John is a 4Y, 5Y
Yeah,
blend.
it's beautiful. You know, and I was sort of an anti-zirconia guy for a long time. I was an Emax guy, and I think it's because the early zirconias were just so bad.
Oh God, yeah.
Yeah, and so, but now I got to say, I mean, it's the 4Y5Y is beautiful. At what point did I did the lower anterior composites? I did the lower anterior composites when it was printing. So again, since he was basically copying what my wax up was, I did a injection molding technique on the bottom. So I was going off a design. So I knew I was going to be really close when I put the provisional in. But that was a good use of time because about the time I was done with the resins, I had a provisional that I was going to stain and glaze.
Yep.
Oh, that's nice. Pee-wee, who's from Taiwan, he hosted me when I was over there. So he just saying hello. He has to go do an implant surgery. So very different. It's early in the morning tomorrow there. A couple questions about CoSoft.
9 a.m.
Our group wants to know what the current costs of the 3Shape XK software are now. It's all over the place. With our group, the Benco is giving a pretty good discount on the 3Shape software without Model Builder, about $3,800. With the Model Builder, it's about $6,000, which is considerably less than what I paid. Exocad is similar. It's just tricky with Exocad because it's so modularized. By the time you get everything you want, it starts to come up. So you just have to be specific about what you want. But I would say that, as low as 38, probably as high as about 8, depending on all the bells and whistles you've got. If you want Implant Studio, it's a lot more. So that's why I use Real Guide, or I have Lee do the implants for me. All right. Kevin, hey, John, could you please reply to my email I sent last week? Kevin mentioned, sorry, Kevin, I will get to it. I've been a little busy. Thank you for the presentation. All right, let's just finish up. So why did I go digital? I will say probably the biggest reason I went digital is one of them was practicing with my daughter. I definitely could see the things that she was interested in and see where dentistry is going. And I just wanted to help her tie the things she's learning at the Institute and with the time when I was teaching at Dawson, that she had these concepts in a digital world. So we've had a hell of a lot of fun doing these things together. And the last thing that I would say is, right before Pete died, Dr. Dawson died about 2 weeks before he died. He was at our lake house. And, we had some deep conversations that weekend. He knew he was dying. And he expressed to me some pretty big fear about where digital dentistry was and the potential for his life's work to go down the tubes. And so I really want to challenge you that are out there, people at the Pankey Institute that hold all these principles near and dear to our heart. We have a huge responsibility to make sure that these principles don't just live in the analog world. Okay. The digital are done properly will allow us to do things more efficiently. It allows us to communicate better. Is it perfect? Is it 100% perfect? Are we working at 0 microns? No, right? I mean, all those things, everything's got some error. But I do firmly believe now that we can do everything that we could do in the analog world more efficiently and more accurately, day in and day out. And so the more I go down this road, the more I believe that. So a lot of this is my way of my why being in honor of Pete. Why should you go digital? It does allow for increased consistency and predictability. It's definitely going to allow you to collaborate with labs at a completely different level and your specialist. It will allow you to communicate better with patients, showing people digital designs versus stone models. I mean, they're used to being at doctors and looking at screens and just feel like they get it better. And there is a massive time savings when implementing complete dentistry workflows. One of the things that I can tell you for sure is that the longer you do this, you start to realize and understand that the further we get along in our career, our greatest currency is time. And the way we have time for love, and the way we have time for worship, and the way we have time for play is by getting control of the work side of our life. And if we can do that, we start to have time for these other things. So, for Lee and I, our mission is to empower dental teams to enhance clinical outcomes and profitability by transitioning to effective digital technologies and workflows. And maybe most importantly, all while upholding the core principles of aesthetics, occlusion, biology, and structural integrity. What you can trust from us is we're not doing digital just to do digital, right? We're not going to do it if we can't do it as well. And so we want to make sure that you know that if we tell you that it's ready, and again, we'll have a few little bumps along the way, but let us have the bumps. And when we tell you it's ready, it's ready. So for those of you that are interested, we do have the Digital Mastery one-year mentorship program that is through the Pankey Institute. And you can talk to Alex at Pankey. She can tell you all about it and how to join. You can also see the information on ccdigitaldental.com. And if you have questions for me about it, this is my email. Just email me directly. I'm happy to jump on a Zoom call with you and talk about what's going on in your practice and if it's a fit or not. We also do a Digital Mastery hands-on course. Whoa, that was weird. There we go. Digital Mastery hands-on course that next year is April 9th through 11th. And this is really, if you're ready to do it, what I'd recommend is you just do the online one-year program, because it's basically comprised of group coaching sessions and about 40 hours of videos for you to learn all the aspects of digital, whether you're going to do software or printing, and it's designed for you to be able to implement this. If you are at a point where you want more information to figure out how you're going to do that, that's what really the hands-on courses. And Dr. Becker's involved with that with me, along with a couple other people that we've been training on, Dr. Cruz Orket, Noemi, and Charlie Wall. So that's a really fun one. We just did it last in May.